Today's topic is perianal abscess and anal fistula. It is a very important, challenging topic. I find this area more challenging than cancer surgery because of the finesse which is required and the challenges and the complicated nature of what we're going to discuss about. So it's a very important topic, and so we can get started. Right. So I'm Dr. Venkatesh Munikrishnan, a consultant colorectal surgeon at the Apollo Main Hospital, Chennai, and the Chennai Colorectal Clinic. So let's start off. So as we know that there are three important perianal conditions or diseases. One of them is piles or hemorrhoids, which we will touch in the next few weeks. We've looked at anal fissure a few weeks ago and discussed the different options, treatment options, problems associated with it. So this week, we're going to concentrate on anal abscess and anal fistula. As I said, it is a very challenging area and needs to be managed by a person who deals with lots of these conditions or by a specialist, okay? So let's go back into normal anatomy for a minute, because this is important to understand. As you know, whatever food we eat goes through the food pipe, gets digested in the stomach. The food material comes into the small intestine, and in the small intestine, the necessary nutrients are absorbed, and the waste material comes into the large bowel or colon, and finally comes to rest in the rectum, which is evacuated outside. Now, around the rectum is where our area of interest is today. So the wall of the rectum becomes the inner muscle or the internal sphincter, and the pelvic floor or the muscle. There are two sets of set of muscles in the abdomen. One between the chest and the abdomen, called the diaphragm, which separates the abdomen and the lungs and heart. And the next is the pelvic diaphragm, through which the rectum, the vagina, and the urinary urethra from the bladder, the urine pipe, comes out. Now, these muscles are very important to coordinating and evacuating your fecal matter, and it's very important that they are preserved and looked after. Now, as I said, in the rectum area or the anal area, there are two important muscles. One is the internal sphincter, which is the wall of the rectum, which becomes internal sphincter, and then the external sphincter, which is from the pelvic floor. Okay, so there are two muscles which are very important. So I'm just going to put this on Facebook Live so that, on watch. Okay, sorry about that. Okay, so as you said, there are two important muscles around the anal region: the internal sphincter and the external sphincter. The internal sphincter, is involuntary. Okay, it's like your heart. It automatically, when there is when there is fecal matter coming into the rectum, and it comes and sits in this area, there is a message which goes into the brain, and that through some nerves, and automatically the internal muscle will open up. But you may be in an important meeting or in a conference or traveling, then you can't just let open and evacuate. So you use your external sphincter to control. The external sphincter or the muscles are like for example, your biceps muscles. You lift something, you're voluntarily lifting. So they are voluntary muscles. So the external sphincter is a voluntary muscle. So you can contract it or control it so that the motion evacuation is held for some time, and then you can evacuate it where it's when it is convenient. Okay, so there are two muscles, very important. Now, these muscles are critical for control of your bowel movements. One, holding on to gas. When you're passing of gas on a daily basis is normal, and to coordinate that, you need these muscles to work very effectively. Also, when you have, say, when you have gastroenteritis or diarrhea, so there is stool, which is hard or soft, and then there is gas, which is and then there is liquid stool, which you can get in times of diarrhea. Now, so this whole area, anorectal region, which is this area, needs to coordinate these things or identify what type of material is coming down, and then if it's just gas and it's convenient around, you can pass the gas out, right? and and if you go to the toilet to evacuate. So there is lots of important clockwork, as I call it, happening around the anorectal region. So that's why it's very sensitive area to there is many important things which are happening in coordination. So any disturbance around that area is going to cause trouble. Now, the other thing to remember is that these are hemorrhoidal cushions, as I told you about, and then these get swollen up when you have constipation or straining, and that's when again the brain thinks that that's stool, and then you try to go have incomplete evacuation. We talked about it on other times. I'm just trying to touch those points. So these muscles, the internal sphincter and the external sphincter, are critical for control, and they are very important. Now, you also have these anal glands, which are pointed out here. Anal glands. These glands, we're not sure, and we call them anal columns. Just around that, you can see little columns over there, and these are like all around. They have anal glands. Now, we're not sure what they exactly do, but the important thing to remember are that we think that it helps with lubrication, passing the stool out. But the main thing which we need to be concerned about is that these glands can get infected. Okay, they can get infected because of stool getting stuck in there, or some debris getting stuck in there. It's not what we do. It is just stool has to come down, and these glands get blocked, and they get infected. Now that's where this entire problem starts. So these anal glands between in the anal canal, the junction between the outside skin and the inside rectum, you get these anal glands, and these glands get infected. Okay, and then they form a perianal abscess. So look at this. So sorry. So these glands get infected and they form an abscess. The problem, as I've marked out with this yellow thing over here, or coloration, is that these glands form an abscess. Okay. Now, it's like, I tell people, it's like having a pimple in the wrong place, which it is. That's how what I tell my patients. So these glands can burst out and come and drop through the anal canal. But what happens is they burst out through the muscles. And now that's where the problem happens, because as I told you, these muscles are very important to control your defecation and motion control and whatnot. So the problem now is that these muscles are, the abscess bursts between the muscles or through the muscles. Now, if the infection is in the tissues and it doesn't come and burst out through the skin, then it's called a perianal abscess. It's if they burst out through the skin and there is a track and there is pus coming out through a little bead or a little opening on the buttock over here, then it is called a fistula. Okay, so if the infection is within the muscles and tissue, it's perianal abscess. If it comes and bursts out through the the buttock skin, like through a small hole, then it is called a fistula. Okay, now, what are the common symptoms? The common symptoms which you can get anal pain. You can have a temperature if there is an abscess, because there is infection, so you can get fever. You can get a lump, which is painful. You can see pus discharge when the abscess bursts out, or then it has burst out and formed a tract when you have a fistula. You can have symptoms of incomplete evacuation, and also have itching because of this discharge. So these are all common symptoms which we again seen with other perianal conditions. So the important thing is, when you have to go see a doctor, the important thing is to examine this entire area. This is very, very important, because at this point the doctor needs to differentiate whether this is an abscess, a fissure, or an intersphincteric abscess. An intersphincteric abscess is when you have an abscess between the muscles. I'll show you another picture. So what I'm trying to say is, you have some pain, we'll give you some antibiotics. It's not the way to deal with these things. We need to assess if you have an abscess which needs drainage, because if it's an infection, you have fever, discomfort, and the treatment for that is not antibiotics. Any abscess, if there is a lump which has got a collection of pus, it needs coming out, right? The antibiotics will just dampen the process. Most of the time, you will end up with an operation and at some point to drain the infection. So how do you assess? What are the tests which can be done? Obviously, the first thing is a clinical assessment, and then you can do two things. One, if you have access, you can do an endoanal ultrasound, which has got a probe like this, and which we do have in our clinics at the main hospital at Apollo, and in our clinic. So we can do an endoanal ultrasound to assess the muscles and sphincters and look at these infections. Or you can get an MRI, which is the gold standard, and we can get a test called an MRI fistulogram. Okay, an MRI test which assesses these glands beautifully, right? So these are the two important tests. The most commonly used test, although, is the MRI scan. Now, X-rays, which is called fistulograms, taking X-rays, have been done in the past, but they're not very specific, and sometimes they can give you false information. And in this day and age, MRI is the gold standard test for testing an to test or confirm or look for a fistula. Now, do all fistulas need MR? I don't think so. A simple fistula, which is based on a clinical examination, can be managed without an MRI scan. If it is a complex fistula, yes. Or if a patient has had a fistula surgery and the patient has had a recurrence, then we need to get an MRI scan, right? So is that clear? Or clinical examination, very important. Simple fistulas, which can very obvious, doesn't need any further testing. But if it is complex, it's lots of tracks, which I'm going to explain in a minute, then you need a test, MRI scan. Okay. So just look at this. So this is the rectum and this is the anal canal, and we put our finger and check. These are internal and external muscles. So there are different types of abscess. Now, the first thing which I would like to for you to understand is an intersphincteric abscess, like an intercity bus between two muscles, between two cities. Okay, intercity, intermuscle. So intersphincteric, two sphincters, right? So this is an intersphincteric abscess. So this space, if you can see here, is only a few millimeters. And if you put 2 or 3 ml of pus in there, it's going to hurt. Typically, patients say it's like putting a hot poker, hot poker in the anal area. That's how patients will feel when they have a intersphincteric abscess or so the important thing to differentiate, which I also find challenging in my practice, is that when you have an anal fissure and an intersphincteric abscess, sometimes it can be challenging to differentiate, right? Now, but the way to differentiate in my practice is that if the pain is there all the time, it's probably an abscess. If the pain comes typically after a bowel movement, it is a anal fissure. So it's a bit technical, complicated. You don't need to know that, but the information is out there. It's important to know that there is something there. That's what is important here. Now, the intersphincteric abscess, common again, or an ischiorectal abscess, which is in the buttock. This is in the buttock, This is the, bone which you can feel on your buttock on either side. And this is the fat which you feel when you touch your buttock. The softness comes from the buttock tissue, or ischioanal fossa we call. And this is an ischiorectal abscess. Now, the other abscess is a perianal abscess, which is just around the anus and just underneath the skin. The ischiorectal is more complicated because it goes into the fat and it's big abscesses. So most common things you'd see are perianal abscesses, or just over here, or an intersphincteric abscess. Very complicated ones are supraelevate abscess, which is very deep and complicated. So just to know that there are different types of abscess. Some are very simple, you can just drain them. Some are very complex and they need to be managed in a specialist way, in a specialist center, or somebody who does lots of these things. All right. So perianal abscess all are very common. Very, very common. It's like, it starts from the infection of a anal gland. As I said, there are different types. Simply, the treatment is drainage. Antibiotics are an option. So antibiotics are an option just to reduce the inflammation. They don't treat the problem. So if you have an abscess, you need it drained. So that's what the first thing is. Now, the important thing to remember, and sometimes it gets missed out when you have a discussion with doctors, that after drainage, 45% of these perianal abscesses will eventually end up forming an anal fistula. It's not that if you drain an abscess, it's just problems gone. Because I told you, these problems start in the anal gland and they form an abscess. Now, if you drain the abscess, the internally where this gland starts forms a tract, and they eventually will result in a fistula tract. So I'll show you the picture a bit later, but that's what. So what to remember is, if you have a perianal abscess, it needs drainage. And if it's better to be done by somebody who does a lot of this, or a specialist, antibiotics may help to reduce the inflammation, but they're not the treatment. And 45% of these abscesses will, after treatment, after drainage, will end up forming an anal fistula. Okay. Now, as I said, how do you feel? we're talking about anal fistula now. They end up with a small anal lump around the anus, and there's a small hole which is discharging blood or pus or a bead of pus as you press it. So as you can see, as I told you, so these are glands, or which I've told you about, where the crypts are. These glands form an abscess and they come and burst out, and so that's an internal opening. There is a hole on the inside in the anus, and there is an opening on the skin outside, or in the buttock, around the anus. So that's an external opening through which the pus comes and discharges. So you can see there is an anal fistula tract. So imagine like two ends, like a tunnel, right? One end of the tunnel is in the anal canal, and one end is on the perianal, or the skin around the anus. So when the two ends are connected, they are a fistula. If they are not connected, only one end is open, which is internally, and the externally it's not open, then it's a perianal abscess. Okay, simple, just to remember. So this can be painful. It can have on and off symptoms. So what happens is, so the pressure builds up, motion comes down, goes into this internal opening. I told you 45% of the abscess which are drained will end up in a fistula. So the tract remains, and motion comes down a little bit, gets into this tract, something gets blocked, infection pursues, and then the pressure builds, pus collects, and then comes and bursts out. And after the pus is discharged, the pressure settles down, and this outside opening, or the external opening as we call it, can close for some time. It may be a few weeks, months, sometimes years, and then it will reactivate when another time some of the fecal material or the bowel motion bits go into this tract over here, and again sets off the infection. So that's why anal fistulas 99.99% of the time will need some form of treatment, surgery. They just don't go away. All right. So that's very important to remember. So this is an anal fistula. Now these fistulas can be different types. Okay. So if you look at this, you can see this fistula tract is very simple. It's just coming straight. But these fistula tracts, as I told you, internal sphincter, external sphincter, interstitial, I told you, intersphincteric abscess. So this is, if it's going through one muscle or so there are two ways to different important thing to remember. Now, is the tract going through one muscle, no muscle, one muscle, or two muscles? Okay. So as you can see, the tract can be just underneath the skin, or it can go through one muscle, as in this case, or it can go through both muscles, or it can go through a very high level, because if it is very low and very simple, it's easy to treat. If it has got a complex root and it's going all over deep inside, then we are in for a huge challenge. So that is why anal fistulas, my humble suggestion is that if you have it, please go see a specialist or someone who deals with a lot of these things. It is always simpler to treat them when they are simple problems. If you ignore them, they try to put up, so as I told you, this tract will close, and then the infection will occur, and then they'll form another side tract, and they can go up, down, wherever, path of least resistance. Some of say physics, yes, but a path of the infection will go where it finds it easier to go at that point in time, and then you'll end up with multiple tracts inside and a more complex problem which may need for complex treatment. And then that's when and then patients often come to me and say, sir, why, sir, 2 surgeries, 3 surgeries? Because it is complex, and it's these are not big lumps which takes. These are 1 millimeter tract which causes inflammation. You have to, it's like finding a needle in a haystack. So please, perianal fistulas and perianal abscesses are something which should be taken seriously, and if treated at an early stage, we are much better off rather than leaving them at a late stage. Okay, so there are multiple. That's all you need to know. It can be complex. So I try to differentiate them into simple anal fistula and complex anal fistula. That's what you need to. A simple anal fistula, when the tract is very low, as you can see, we're very low in the anal canal. So you put a probe and it's there, and you cut it with diathermy knife, mostly diathermy, or a laser, and then you just allow it to drain. Yeah, all associated tracts or abscess can be drained, and it's in a low fistula, the muscle involvement is very less, so there is no chance of you damaging the muscle or causing incontinence or anything like that. So we just lay it open, and most of the time, majority of the time, it's absolutely fine. No problem. Yeah, without any major issues. So simple anal fistula can be just laid open, and most of the fistulas, simple anal fistulas, right? but they should be treated early. If you leave it, then this external opening can block off, and then it can put a track up, and then it complicates it. Okay. So even in the simple, the important thing is to find the internal opening. The root is where this problem starts. The external one you can easily find. The root is when which needs to be found and laid open. If you don't find the root, and if you just scratch on the outside or laid partially, sometimes I find it challenging to find the internal root because it says inflammation, the track's not clear. My tendency, the way I deal with it is, if it's not easily going, if I have several techniques of putting some dye or identifying the root. If it's not, we just try to leave that and come back at another date. Although the patients may find that, doc, why didn't you do? Rare, but it's much safer to identify the root easily. If you don't, you try to push it through, or you do more damage or create false tracks, as we say. So simple fistula, lay it open, usually it settles down. Complex fistula are the most challenging. Now, patients who have the problem need to have patience. The surgeon has to have patience. So both have to work together, because if it's a complex track, we have to remove look after the muscle which control the motion, preserve that, and at the same time remove the track. So there are two things to achieve here, right? To remove the problem, and also to make sure the muscle is not damaged. Any abscess, if it's there, needs to be drained. And if complex fistula should be managed by specialists, or guys who do, or girls, doctors who deal with it regularly. Because as I find often, I find them more challenging than cancer surgery, because they are infection, which are like, could be 1 millimeter tracks, which in a very sensitive area, and it involves the muscles which control your motion. So please remember this, that don't ignore the symptoms. If you have a fistula, they need to be treated. The sooner the better. Work with your doctor and find a guy a doctor who does lots of these things. So we'll talk about Acetone placement in a minute. So when you have a complex fistula and there is infection, and you now don't know, and there's a lot of muscle involved, the simplest thing which I do often, and a lot of surgeons, colorectal surgeons will do, is to put in something called a Acetone, which could be a suture material or a rubber sling through the track. So I told you these are tracks, as you could see. Now you have to, as I said, if it's a low track, you can just cut it and then it's laid open, it's done. But in this case, as you can see, there is a lot of muscle involved. So that is when I tell patients, see, there's your scans or the clinical examination confirms that's a lot of muscle involved. We can't just cut it. We may have to do it in few stages where we have to put a Acetone, so that associated abscess infection all drains. Because basically what you're trying to do is to keep the track open so that it doesn't close with a structure, which could be a physical thing, which could be a Acetone or a suture or any material, so that all the infection comes out. And this track over a period of time will shrink and become clean and become easier to treat. So as you see this picture again, this is red in color, the Acetone. These are the pink are the external muscle, the blue or the green is the internal muscle. And there's a lot of muscle here. So if the track was very low here, then it's easy to cut it out. But if it's at a higher level, you can't cut. You have to put the Acetone and allow all the infection. So if you leave the Acetone in, the tracks won't close, all the infection comes out, and tracks will shrink and scar, and it becomes easy to treat later. So that's why Acetone is useful for managing complex fistulas. So what else is available? So we have long tracks of it. It's something which is becoming popular, is a lift procedure. The lift procedure is where basically, instead of cutting the muscle, you cut so you can see the track is going through the two muscles. This is the rectum through which we put our finger in. This is the internal and external muscle. You can go between the two muscles and then, block off this track, right? That's what they've done over here. Go in and tie off these two tracks so that anything comes in which gets blocked off here, it doesn't go, and this will eventually dry up. It's called a lift procedure. Better for sphincter control, because you're not cutting the muscle. The problem with these procedure is that if you have a lot of infection, you can't really find all these things, and complex high tracks you can't. So some nice straight track, it can be tried. But again, success rates are about 60%, 40% failure rates with these procedures. There are guys who do amazing lift procedures. Very few centers in the world. Only, we've not been able to replicate the high success rate. So somebody says, look, doc, I don't want to damage my muscle. I know, can you try the lift procedure? Bearing in mind that 60% of the time it'll be okay, 40 to 50% will come back. Then we can try that, So those are the options which we can give. So the other thing which you can do are, because when you have a high fistula, complex fistula, you don't want to damage the muscle. So you want to try to see if you can block the track with something called a fistula plug. They tried glue. Imagine there is a track and you don't want anything to buy, you put glue, right? With a pressure pump and put a glue in. Like that, you could do that for these fistula tracks also, or put a special plug. Again, or you can try this something called waft fistuloscopy, which we do have in the Apollo main hospital, and we've tried it in several patients. Again, all these things are sphincter preservation ones. These are like endoscopic treatment of fistula for complex fistulas. That's all you need to remember. So simple fistula, lay open. Complex fistulas, you try to preserve the muscle, and you have to be prepared that you may need you may need acetone to drain the infection. You may need 1 or 2 procedures or 3 procedures sometimes to work on these tracks, and bearing in mind all these new techniques will have a failure rate about 40%, but it will preserve the muscle. You're not damaging them. So it is a compromise, but it should be tried as long as the patient accepts these risks. The other thing to do are endoanal advancement flaps, where basically you take a bit of plastic surgery type thing to take a bit of the flap in a healthy tissue and close off the internal opening. So these are the different things which you can do for complex fistulas. Okay, so if it's complex, it's a lot of infection drained with acetone, and then you try one of these techniques to get rid of the problem. Okay, the main thing to why we're doing this, to preserve the function of the muscles so that we don't damage the muscles. Okay, so that's why the fistulas are complex or challenging. Okay, so I hope that sort of gave you a summary of what this problem is. So it's an anal gland infection. We don't know why it starts, but that's where it starts. And then, as I say, it's a pimple in the wrong place. Okay, so I would like you to ask questions on the chat box. I will reply to the messages and questions when I finish this show shortly, and then I will, message you or talk to you about what needs to be done if you have any problem. Now, to summarize, so as I said, the anal glands get infected. We don't know why, but that's how it starts. So as I said, pimple in the wrong place. And then this abscess bursts into the muscles, which control the motion. That's where the problems start. So if you have a perianal abscess, the treatment is always, or fistula, is surgery. If it's a perianal abscess, any infection abscess needs to be drained. Antibiotics have a limited role. They reduce the inflammation temporarily. So popping antibiotics has lots of side effects. Please don't do it. See a guy or a girl or a doctor who, a specialist who deals with these problems, because they are challenging. Now, after you drain a perianal abscess, 45% of the abscesses will develop into an anal fistula. So that's something to remember. So sometimes patients come to say, sir, I had the treatment done and it's come back. I think the doctor didn't do a proper job, or, I think, so I tell them, look, the nature of the condition, the natural evolution of this problem of perianal abscess is that when you drain an abscess, 45% of them will end up with a fistula, because the tract still remains. You've just drained the abscess on the outside, the root is still there, and it will form a fistula at a later stage in 45% of these cases. As I said, anal fistulas are challenging. I find them more challenging than cancer surgery, because it involves the muscles which control the motion, and they need to be managed by experts who deal with this on a regular basis. The main component of managing fistula, as I said, simple fistulas can be laid open. Complex fistulas, patients and the doctor have to have patience, and they need to work together, because this can be a long drawn out process over a period of 3 months, 6 months, a year, because of depending on the complexity of the anal fistula. The important thing here is to drain the infection and preserve the anal sphincter muscles, and to preserve continence. So this is very, very important. So patience is paramount in managing anal fistulas. Perianal abscess is very straightforward. You drain it, right? An anal fistula, if it's simple, you lay it open. If it's complex, you need to have a armamentarium of different treatment options to clear the problem. And as I said, 40% of the time, all these options may fail because you're trying to preserve the muscle, and you're dealing with infection. So it may need 1 or 2 sittings to clear the problem. So, and if you lay it open, if it's a complex fistula, sometimes you may end up, having urgency because some of the muscle is. So if there's a little bit of muscle involved, you can lay it open. You still will have control. So that's a compromise which the specialist will discuss with the patient and say how preservation of 100% in a complex anal fistula, the control, everything can be challenging, and that's why experts need to manage that. I hope the session was useful, and we will meet soon in a few weeks with the next focus topic, and I'll put that out on the Facebook page. Please follow our YouTube channel, follow us on Instagram, follow our Facebook page, and you'll find all these videos there with explanations and subtitles. And please do share with your friends and family. And I hope you're all staying safe. Wear your masks, maintain social distancing, and stay healthy. See you all soon.